This is a screencast describing the genetic disorder Prader-Willi Syndrome. Prader-Willi Syndrome is a genetic disorder in which 7 genes on chromosome 15 are either deleted or unexpressed on the paternal chromosome. Characteristic of Prader-Willi Syndrome is low muscle tone, short stature, incomplete sexual development, cognitive disabilities, problematic behaviors, and a chronic feeling of hunger that can lead to excessive eating and life-threatening obesity. There are 3 known causes to Prader-Willi Syndrome. The first cause is an imprinting mutation. For most genes, we inherit 2 working copies, one from our mom and one from our dad. But with imprinted genes, we inherit only 1 working copy. Depending on the gene, either the copy from your mom or your dad is epigenically silenced. Silencing usually happens through the addition of methyl groups during egg or sperm formation. The imprinting error associated with Prader-Willi syndrome takes place on band 11 of the long arm on chromosome 15, on the paternal side. The second cause of Prader-Willi syndrome is known as uniparental disomy, or UDP. It is responsible for about 30% of Prader-Willi syndrome cases. Uniparental disomy occurs when a person receives 2 copies of a chromosome or a part of a chromosome from one parent and no copies from the other parent. UPD can be the result of heterodisomy, in which a pair of non-identical chromosomes are inherited from one parent, or isodisomy, in which a single chromosome from one parent is duplicated. The image above is a representation of UPD. As we can see, we have the father chromosome and the mother's chromosome. However, the child only receives maternal chromosomes. Therefore, he has maternal uniparental disomy, which would cause Prader-Willi syndrome. The last known cause of Prader-Willi syndrome is Prader-Willi syndrome by deletion. Most often, part of the chromosome 15 that was inherited from the person's father is missing or deleted in this critical region. This small deletion occurs in approximately 70% of cases and is usually not detectable by routine genetic analysis. Again, this deletion occurs on the long arm of chromosome 15. Prader-Willi syndrome has various symptoms and ways of manifesting itself in the different stages of life. In utero, Prader-Willi syndrome will result in reduced fetal movement, frequent abnormal fetal position, and occasional excessive amniotic fluid. At birth, Prader-Willi syndrome will often cause lethargy, hypotonia, which is a case in which there is a lack of muscle tone, feeding difficulties establishing respiration, and hypogonadism. In older infancy, Prader-Willi syndrome will cause continued feeding difficulties, a lack of intellectual development, excessive sleeping, strabismus, which is something that causes crossed eyes, scoliosis, and cryptorchidism, which is the absence of one or both testes from the scrotum. There are also several neurocognitive implications of Prader-Willi syndrome. Individuals with Prader-Willi syndrome are at risk of learning and attention difficulties. IQ testing performed in 1992 to test the various levels of IQ in Prader-Willi syndrome patients revealed that the majority of Prader-Willi syndrome patients have an IQ between 50 and 70, which is described as mild intellectual disability. 40% of individuals with Prader-Willi syndrome have borderline to low average intelligence. Additionally, children with Prader-Willi syndrome show an unusual cognitive profile. They are often strong in visual organization and perception, including reading of vocabulary, but their spoken language is generally poorer than their comprehension. Auditory information processing and sequential processing are relatively poor in Prader-Willi syndrome patients, as are arithmetic and writing skills, visual and auditory short-term memory, and auditory attention span. These sometimes improve with age, but deficits in these areas remain throughout childhood. There are also several behavioral implications of Prader-Willi syndrome. Prader-Willi syndrome is also frequently associated with extreme, insatiable appetites, often resulting in morbid obesity. It is the most common genetic cause of morbid obesity in children. There is currently no consensus as to the cause for this particular symptom, although genetic abnormalities in chromosome 15 disrupt the normal functioning of the hypothalamus. Given that the hypothalamus regulates many basic processes, including appetite, there may be a link. In the hypothalamus of people with Prader-Willi syndrome, nerve cells that produce oxytocin Oxytocin is a hormone thought to contribute to the feeling of satiety. As a result of this lack of normal hunger and satiety cues, patients with Prader-Willi syndrome usually are not able to control their food intake and will overeat if not closely monitored. Food-seeking behaviors are very common. In addition, the metabolic rate of people with Prader-Willi syndrome is lower than normal. Left untreated, this combination of problems leads to obesity and its many complications. The primary mental health difficulties experienced by people with Prader-Willi syndrome include compulsive behavior, which is usually manifested in skin picking and anxiety. Psychiatric symptoms, for example, such as hallucinations, paranoia, and depression have been described in some cases and affect approximately 5 to 10% of young adults. Psychiatric and behavioral problems are the most common cause of hospitalization for Prader-Willi syndrome. There are several aspects of Prader-Willi syndrome that support the concept of growth hormone deficiency in individuals with Prader-Willi syndrome. Specifically, individuals with Prader-Willi syndrome have short stature, are obese with abnormal body composition, have reduced fat-free mass, have reduced lean body mass and total energy expenditure, and have decreased bone density. Prader-Willi syndrome is characterized by hypogonadism. This is manifested as undescended testes, and testes may descend with time or can be managed with surgery or testosterone replacement. When analyzing the diagnosis of Prader-Willi syndrome, it's important to keep in mind that it affects approximately 1 in 25,000 newborns annually, and that there are more than 400,000 people who live with Prader-Willi syndrome around the world, making it a relatively common genetic disorder. As I said before, Prader-Willi syndrome is traditionally characterized by physical detriments such as hypotonia and short stature. However, with early diagnosis and early treatment such as growth hormone therapy, the prognosis for people with Prader-Willi syndrome is beginning to change. Like autism, Prader-Willi syndrome is a spectrum disorder, and so symptoms can range from mild to severe and may change throughout the person's lifetime. Currently, the syndrome is diagnosed through genetic testing. Testing is recommended for newborns with pronounced hypotonia. Early diagnosis of Prader-Willi syndrome allows for early intervention as well as the early prescription of growth hormone. The mainstay of diagnosis is genetic testing, specifically DNA-based methylation testing to detect the absence of the paternally contributed Prader-Willi syndrome region on chromosome 15. Such testing detects over 97% of cases. Methylation-specific testing is important to confirm the diagnosis of Prader-Willi syndrome in all individuals, but especially those who are too young to manifest sufficient features to make the diagnosis on clinical grounds, or in those individuals who have atypical findings. However, a common issue is misdiagnosing Prader-Willi syndrome as a variety of other syndromes due to many in the medical community's unfamiliarity with Prader-Willi syndrome. For this reason, it is often misdiagnosed as Down syndrome. Prader-Willi syndrome currently has no cures. However, several treatments are in place to lessen the condition's symptoms. During infancy, subjects should undergo therapies to improve muscle tone. Speech and occupational therapy are also indicated. During the school year, children benefit from a highly structured learning environment as well as extra help. The largest problem associated with the syndrome is severe obesity. Therefore, prescription of daily recombinant growth hormone injections are indicated for children with Prader-Willi syndrome. Growth hormone supports linear growth and increased muscle mass and may lessen food preoccupation and weight gain. Additionally, the only way to deal with the extreme excessive eating is through careful diet monitoring. Many of the possible related complications of Prader-Willi syndrome result from obesity. In addition to having constant hunger, people with the disorder have low muscle mass, which requires lower than average calorie needs. This combination of factors makes a person prone to obesity and the medical problems related to obesity. These possible complications include type 2 diabetes, right-sided heart failure, as well as orthopedic problems. A less common complication is known as sleep apnea. This sleep disorder is characterized by pauses in breathing during sleep. The disorder can cause daytime fatigue, high blood pressure, and rarely sudden death. People with Prader-Willi syndrome may have sleep apnea or other sleep disorders even if they aren't obese, but obesity can worsen sleep problems. That concludes this screencast on Prader-Willi syndrome.